real pleasure to be with you all today. As I say, I've come from Leicester, so it was only 45 minutes across the Irish Sea, and as I say, the world is a small place, and as I say, there's so much commonalities that I'm hoping and already had chance to hear and share, and it's a real honour today to be able to speak to you and share my experiences. I've worked in quality improvement for 20 years within the NHS, and we've come on quite a journey, and I'm wanting to hopefully be able to influence that. And part of quality improvement is about learning from others and adapting other people's ideas and adopting or discarding if they're not very good. So I'll let you be the judge of what we've done in England, and as I say, we've got lots to share. So lecturing's not necessarily my style, so and again, I want to try and make this as interactive as possible. I know we've got a debate later on, but can to start, just have a show of hands. Who thinks quality improvement is their responsibility or part of your jobs? Brilliant. Okay, so I'm talking to the converted. That's a good start. So yeah, excellent. So start with slide set in a moment, but Don Berwick's got a great saying. Anybody know who Don Berwick is? Yeah, paediatrician from America, but he also is a lead for the Institute for Health Improvement. And he's got one of his sayings that I like to use. In healthcare, we've got two jobs: to do our job and improve our job. And that's absolutely, I think, linking the stars. That's all about making sure everybody's role within a team of looking after a patient comes together and provides the outcomes that we'd expect. And hopefully through this afternoon's discussions, we can see how clinical audit is a fundamental part of a patient experience and influencing outcomes when we look after patients in a hospital setting. So yeah, so who am I to talk to you for the next 35 minutes or so? So yes, as I say, I've worked, I was a statistician, grew up wanting to be a sports statistician. But I wanted to be a footballer before I did that, but I wasn't that well. I was all right at football, but didn't cut the grades. So my next hobby was collecting data and analysing it as a child, which was a bit unique, I think. So I'll perhaps catch you at coffee time if anybody else is interested in statistics. But the point is that I had a passion around looking at data, understanding what that data is telling us, and then making decisions around that data. And I went to university to use that and harness those skills. And people talk around statistics, and sometimes people turn off because it's quite a complex language. But actually, data is fundamental to the health care these days. We can't do anything really without data. If we don't measure what we're doing, we don't know what we're doing. So it's absolutely important that we have good measurement in place to make sure we know how we're doing. And as I say, during my time over the last 20 years, I've seen sort of a revolution in terms of clinical audit coming out in the early 1990s. It looks like we've got an interactive slide here. I'll just whiz by that. So yeah, so our clinical audit journey in England started in the 1990s when we had a white paper out from the government talking around the importance of medical audit. And over time, that's evolved under different sort of headings, but ultimately it was all around having a standard and measuring how you're doing and trying to improve patient care. And over the years, as I say, that's evolved slightly in terms of the definition that we've worked within, but ultimately now, and since NICE defined it in 2005, I think, as a quality improvement process, it's important that what we do is linked to improving patient care. So okay, so yeah, so a timeline. Clinical audit's been in the NHS since 1990s, as I say, and so have our networks in terms of, we used to have sort of somewhat an unfortunate acronym, I'd say, as NAG. So that was the National Audit Governance Group, and that was set out in 2000. And as I say, that was driven by local networks from the local health authorities at the time. Came together, people, peers, supporting each other, just getting together and sharing good practice. And over the years, that's sort of more formalised, shall I say. We've got a bit of funding that we've had in the past. HQIP have already been mentioned this afternoon, sorry. And they've been fundamental to supporting our networks with helping with some of the costs, which I'll go into later, but also supporting us with the infrastructure of travelling inspectors and venues. So I'd like to thank them for their help in terms of getting our networks up and running over the last few years. But essentially, it's been the people within our networks that have run our networks, and that's what we've always prided ourselves around, and we will always continue to do so as allowed. And again, already given Don Berwick a mention, but when he did the Berwick report in the UK following the Mid-Staff Street inquiry, he was saying collaborative learning through patient safety initiatives is key, and networking is really important to making sure that we don't make the same mistakes. So and we learn and we can share with each other, and again, that's hopefully what we're going to try and do this afternoon. So our purpose and plan, well, we like to think of ourselves, and hopefully we are, as the voice of the clinical audit professional, but also the voice of the clinical audit clinician, because we've got lots of clinical audit leads within our hospitals, and we try our best to make sure that there's consistency in terms of approach, but also supporting each other in terms of what our work plans are, what we've got in our programs, trying to share best practice that way, what should be audited, how do we go about picking the projects that we choose, but also looking at the national agenda and finding out how the national audits are doing, because we've got quite a comprehensive national audit agenda in England and across the UK. And we've had around 50 audits that are commissioned and supported by HQIP, and all trusts are then expected as part of their tariff to take part in those audits. So, and that's been a journey in itself, which probably haven't got time to talk around in too much detail today, but ultimately that's been a focal point that's brought the networks together in terms of a commonality of a project. But as I say, there's trying to be conduits and linking with people to feedback from the shop floor to the people that are making these decisions, people who are picking the priorities to say what we feel is important to improve, but also influencing people like National Institute for Clinical Excellence, NICE, and people who are setting the guidelines in the first place and saying how important it is to know how we're doing against those standards. And as I say, we're trying our best to align. We work quite a lot in silos in the NHS. Everybody's got their own job cards and bags, and what we're trying to do more recently is trying to knit together everybody's work, because, as I say, ultimately we're all there to try and make sure we're providing safe care and improving the care that we provide to our patients. So, and if you have that as the core of what you discuss, then it's quite easy to break down those barriers and find commonalities of how you can work together and support each other with a common purpose. So our networks, we've got, well, as until this year we had 14 networks. We've now got 13 networks because our London network combined, but ultimately, as I say, each of our areas are regionalised, and all of the trusts and relevant bodies within that area are then invited to attend those networks. And then on a once a quarter, we come together at the national level, and all the chairs from those regional networks meet at our NQICAM meetings, along with all of the bodies that I've mentioned in terms of HQIP, NHS England, which ultimately fund both of our work streams, but also the Royal Colleges that provide the national clinical audits. As I say, we've got NICE, we've got the Q initiative, which I'll go on to later, and other experts that attend to present and give updates. So those meetings are quite key in terms of keeping the business flowing, in terms of making a difference. It's nice to see that Suja said earlier that over the last few years she's noticed a difference in terms of the outputs from NQICAN, and that's great to hear, because as I say, when I took up the post, which is nearly 3 years ago now, I wanted to do something and make a difference. So I didn't want to just go to a national meeting and say, oh, that looks good on my CV. I actually wanted to go to those meetings and feedback and actually say, we've got a voice, we've got expertise, and we want to make a difference. So because as I say, when we all work together, things go a lot better, and you have a more of a united approach. So each quarter we have a meeting in London, more often than not, and we have a guest speaker, we have core business to go through, and we keep an audit in terms of minutes and attendance lists, so that we make sure everyone's engaged. And yeah, and that's a typical meeting we had recently in September, where is anybody a member of our forum at all? Oh, well done, very good. I think Susie is as well, yeah. So, I'll go into that more recently, but we have actually opened the who can join that forum now. It was just for NHS staff, but we've now opened that up for anybody who's working within quality improvement anywhere. We had somebody from Australia join the other week, so it's great that word's getting out there. And as I say, we're all trying to do similar sort of jobs in terms of what we do into improving our practice and providing a safe service. So whilst not, as I say, the world's a small place with Twitter and the internet, so we need to try and work together as well as we can. But as I say, I won't go into too much detail there, but you can see we've got lots of different key talks that take place, and then we feed that back through our regional networks and hopefully cascade the learning that way. Another interactive slide, sorry about that. Yeah, so just to say, we aren't lots of money in our networks. In our accounts last year, we had an outturn of £17,000. Yeah. So we're not, by any stretch of the imagination, working with a big budget. So we're always on the lookout for how we can expand our income in terms of trying to provide network events for our colleagues, such as this one that we have. And trying to, increase the skill set and making sure everybody's trained to do the job as well as we can, really. And as I say, economies of scale by having one trainer go across different trusts, then that's more money well spent. And as I say, then that can be then fed back to each of the individual organisations. As I say, but invaluable. But we have our travel and admin covered. And as I say, I have 2 days a month to do this role, and that's paid from HQIP to my host organisation, the Leicester Trust. So again, that frees me up to do 2 days a week, 2 days a month. It feels like 2 days a week sometimes, but to do this in terms of trying to promote what we're doing in our networks, but also leading on some of the work we're doing. We produced an annual report at the outset of my time in charge, because I wanted to try and make it clear what our priorities were. And that annual report, I'm happy to send out a link, because it's been well received, that as. But we set out 5 objectives that we wanted to try and achieve over a sort of a 18-month period, and largely we were quite successful in achieving those. And I'll just give you a few examples of what we've done to do that. So to continue to promote clinical audit as a quality improvement process. It's great to already hear that you feel that audit should be used as an improvement process, but in healthcare, there's 3 reasons why you'd collect data. The easiest way of looking at it, I think, is, are we meeting our standards? If we're collecting data just to prove that, that's for assurance or accountability or judgment. If we know we've got a problem and we need to improve something, then that's for improvement. And then if we don't know the best way to treat patients, we do research. And again, quite often, sometimes when I see a proposal, it is actually just watered down research, and it's trying to do a clinical audit through the back door, so to speak. So, and again, it's quite important that we pick the right tool for the right situation that's going to produce the outcomes that we want. So, and I've already mentioned this earlier, that NICE have said that clinical audit should be a quality improvement process. So, but as I say, there are different conditions to that we've tried to rationalise within Leicester, my trust. And we ask ourselves 2 questions when we see a project proposal in terms of a plan where a project's needed. We first of all say, do we know how we're doing against our standards? If we know how we're doing, then we ask ourselves, do we need to improve? So if we need to improve, then you need to do a quality improvement rapid cycle clinical audit. So because again, from the outset, we know we've got to improve, so we shouldn't be saying, let's take 12 months to collect some data and present that back, and then all of a sudden realise 12 months ago we've got a problem, we knew about that, but we've put off making the changes for 12 months just while we collected the data. So on the flip side, do we know how we're performing against the standards? If we don't, we ask ourselves, should we know how we're doing? And if we don't know how we're doing, a lot of that time is against our own guidelines, or NICE guidelines, as I've said. We do a quality assurance sort of classic first cycle audit to robustly collect the data. And as I say, the easiest ways of determining how we analyse that data is that if we're doing an improvement project, we want to see runtime charts in terms of assessing how we're doing over time and testing how the variation within the system and looking at how effective the interventions we've taken have been to improve our practice. If we're doing an assurance project, then we rag rate and say, how are we doing against the standard? We normally have a target, and then we sort of say whether we're within that or not. And again, unfortunately, sometimes we see assurance being taken falsely on the basis of a poor sample or a poor quick and dirty project, which again, I see as my job to point that out when I'm at an audit meeting. If I don't think there's sufficient data to make those conclusions, then we need to be saying, this is interesting information, but we've got to carry out the audit much more robustly over time and then see if there's any variations and see if this theme continues over a larger data set, but also looking at the different parameters that might be involved. So it's a really important slide there. And again, if you take away nothing else from my slide, then I think that's a useful slide to take back to your organisations and start questioning yourself, why are we doing what we're doing? Is it clear why we're doing it? And then once we know why we're doing it, we can set up the right methodology. And H Group, again, a few mentions, but they've produced a good guide to quality improvement methods, which again I recommend. It's got a page on each of the different types of techniques you can use. So clinical audit and PDSA cycles are the most common ones in quality improvement, but there are lots of other different techniques that you can do to actually develop and improve with some measurement alongside. So, and again, a lot of it's about getting to the root cause of the problem often, because it's all right saying we're non-compliant with the standard, but we need to say, did it affect our outcomes? And if it doesn't, we probably don't need to be too worried, as long as there's not grade A evidence to say that we should be doing that. But also, do we know why we're not following the guidelines? And then looking at the root cause of trying to find out why we're not following the guidelines. So, because again, there's lots of universal techniques that we can have to actually get to the root cause of the problem of why we're not meeting our standard. Because a lot of action plans sometimes say retrain the staff or share the results. That's not getting to the root cause of the problem. Is actually you want to find out why people, because people don't come to work to do a bad job. The system makes them take shortcuts or do things in a different way that wasn't probably intended in terms of best practice guidelines. So speaking to staff and actually having people in the room just talking through the audit is often the best way to come to finding out what the problem is. I had an interesting conversation before we started today about involving patients, and again, in Leicester we're quite keen on hearing from our patients in terms of, did we get it right? If we didn't get it right, what was it that we didn't get right? And then using that to inform our improvement programmes, because we do lots of surveys. Patients spend a lot of time filling that in, so it's important to use that to influence what we do. So a good resource there that you can certainly use, I'm sure, across your networks. Clinical Audit Awareness Week, that's coming up shortly, in about less than 50 days' time now, I believe. So, and it'd be nice if we could get Clinical Audit Awareness Week going global and beyond the shores of England. So please feel free. I'll give you the actual date for this week, but it's more or less the same week as it was last year. But that was. This is just an example of what happened across our networks in terms of everyone sharing what was doing, promoting good practice, making cakes. We've already heard how food engages people. So and people made cookies, biscuits, and all sorts with the Clinical Audit Awareness acronym on there, which really makes people find the time to go and speak to you and find out what's happening. So that's good to use that sort of initiative. We did a talk at Patient First. I talked to a colleague who was there last year, which was great. So, and that was all about trying to raise awareness of what we're doing in our networks, but also signposting to us, because a lot of people didn't know we haven't got a big marketing budget. So what we can do is word of mouth and using social media, etc. So that was great for that. And we've also talked at different conferences that have happened, and I've chaired one or two recently in London, and that's another good way of raising awareness about our networks that doesn't involve any costs, but also able to influence discussions that take place at those events. So certainly worth having, and it's good to hear about your events and the success you've had. So the second thing was providing excellent meetings so that people found the time to go to those network meetings. If you haven't got a good agenda, then more often than not, people will find that the day job pulls them and prevents them to attend. So try and get some good speakers there, try and have a good agenda in terms of why people have a look at the agenda yourself and say, would I attend that event? And again, some examples that we've done a change day where we talked around the importance of how we can have around managing change and human factors around change. But we had a day around looking at all of that. That was facilitated by experts at Clinical Audit Support Centre. And again, 4 regions all came together, and that was an excellent meeting in terms of looking at how clinical audit professionals could influence and work with clinicians when change was needed. We've also done events where we've got people from nationally to speak at, and that was in my local East Midlands event. So, but we had some sort of round the table exercises. It wasn't just a lecture approach, but it was actually hearing back from what people thought around clinical audit, and we even got them doing some snazzy strap lines for clinical audit to try and improve its PR, so to speak, because it sometimes gets a hard time. Says the chip on my shoulder. Okay, and as I say, within the NHS, there's lots of bodies that are having quality as part of their mandate, and we try and make sure that we feed into those and work alongside instead of against. As I say, we've got a very small budget, so it makes sense for us to try and work with others and see what's available in terms of resource and events. So it's been really good with that. But again, we've encouraged our networks, if they've got problems, then write it up and feed it back. If people don't feed back where the problems are, then people aren't going to know what the problems exist. This is a good example from our Yorkshire network, where they felt as if the national clinical audit mechanisms weren't working as well as they could do. So they actually wrote through that as a document, wrote to HQIP, and HQIP then responded to say, actually a lot of things existed, we just weren't aware of them, and signposted them to the results. And some of them then also influenced our work going forward in terms of working with HQIP and friendly challenge in terms of the direction going forward for national clinical audits. There was a publication that came out as well from the Academic of Medical Royal Colleges that was quite damning on clinical audit. I laugh because it was talking about quality improvement being the next best thing, and almost dismissed clinical audit as being old and irrelevant. So we actually said clinical audit is a systematic tool to actually improve patient care. It's the same as any other quality improvement process. So the point is, if you just do one part of a cycle, it's going to fail. If you just ask doctors to collect some data and expect that to improve patient care, it's not going to. So you've got to do the whole cycle. I haven't got a slide about the cycle, that's an oversight from my point, but the whole clinical audit cycle, it's about evolving, and it's more of a spiral really in terms of continuing to evolve what we do. And as a result of that dialogue, we wrote a letter to the lead, and that lead now has come to our meetings a couple of times, and we've got a good dialogue going forward. And in fact, they wrote a publication recently about unlocking the potential Royal College of Physicians, and that was really good in terms of trying to say how we need to support our junior doctors and make sure that they're not used as data monkeys to collect all the data, that actually they're there to try and do a project that will enhance their careers as doctors, not just having to spend a lot of time looking through notes. And I think that might come up in the debate later on about how we find time to do things, so that's worth there. But also, we've now been invited to sit on the boards of some of these national clinical audits, and I sit on the Royal College of Physicians board that looks at the falls, frailty and fracture audit programme. And again, I can hear firsthand of what issues that board are trying to see, and the complications sometimes in terms of trying to send out timely data, and the difficulties of setting up and trying to please everybody in terms of their approaches. So that's been really insightful. So we've done that. So it's a good thing that you could perhaps do in terms of your expertise bodies. And as I say, that there's lots of other bodies, NHS Improvement, Then we're doing a lot of work with making data count. Has anybody seen that publication? No, very much worth. Yeah, okay, so yeah, great. That's all around using plot the dots. Statistical process control is the technical term, but we've tried to make it more simple by saying if you're going to improve something, you've got to plot your dots and have a look over time how things are varying. And really that has been quite key, that we're trying to have a combined approach to that, because, as I say, clinical audit is very poor sometimes at just putting it all together in one chunk and then doing a repeat cycle and putting another chunk and then saying there's an improvement, but actually you don't know there's an improvement. It's just that sample has proved that we're perhaps doing a bit better than we were last time. We don't know. There's been no learning potentially between the two cycles about what was effective and what changes were made a difference. So yeah, and quite key, and this has been really key for the networks. So it's been great to hear Suja saying about the importance of having ways of communicating and networking. Physically, to get together is quite hard, and it's a big undertaking to organise. So the world, as I say, is a small place these days, and IT is a brilliant help, and we need to embrace IT more than we do, I think. We've got a blog now where we can write out messages and cascade around something that's perhaps been raised to us as a concern. A couple of things that I've mentioned already in the talk, but also have a look at things in a more light-hearted manner. So, and again, we can see Santa Claus there on there, but somebody did a take on the Christmas and how clinical audit could look at one or two of the things that we do around Christmas, and sort of parallel and parody sort of thing of it. So, but as I say, it was also, we had a guest blogger who was anonymous, and they challenged clinical audit professionals to take the bull by the horns and really take national clinical audit further. And if it's not working in your trust, find out why it's not working and try and find a way forward, instead of perhaps being frustrated and moan. Actually be proactive and try and do that, because clinical audit is a proactive process. A lot of other things we do perhaps within healthcare is reactive, particularly incidents and responding from complaints and things, but actually proactive measures, there are not that many. But so if we do something and spot that potentially something could go wrong, by doing a clinical audit, then that could stop the never event or the incident that nobody wants to be involved with. So, and again, if we can see that we're not following what we should be doing, then more often than not, before long, that will lead to something that's unintended, and potentially patient harm will be caused. So, so that date for Clinical Audit Awareness Week is 19th of November. Say on social media, there'll be lots on that, I'm sure. So please follow that along. And we've produced a pack this year to help our trusts do things during that week. So as I say, last year lots of people did things, so we've wrote up a sort of a recipe book almost to say, here's a whole lot of different ideas you can do to try and encourage and promote clinical audit within your organisations. And that's there for people to network and say, oh, you did that last year, you wonder how you did that, and use that through sort of our mediums for our website and Twitter site, etc. Going back to the blog site, as I say, we can quite easily, through the internet statistics that you can see how cross-cutting and how far your word is getting via the internet. So, and again, interestingly, I've not really left Leicester in about 20 years, and now in the space of a month I'm going to Ireland to talk, and now I'm going to Saudi Arabia at the end of the month to do a talk. So it just shows that people are out there, they are looking at what you're doing, and again, it's great to know that you can then help and influence other people that are working on similar sort of work in another setting, because it's good, to, as I say, to learn from both ways. That's the Clinical Audit Forum that I talked about, and as I say, it's called the NSF, which is called the Network and Sharing Forum. And as I say, that's a year old now, and we've already got over nearly 700 members. So that's been a brilliant way of making sure and connecting people and sharing best practice. And again, we've got things around where people can talk about the national clinical audits. We can talk about peer support if people have got any concerns in a confidential way. We've got audit tools that people say, we've done an audit, here's the audit tool if you want to use that. Let us know if you want to share results or whatever. And again, there's lots of teaching and resources available that people can use and we signpost them to that via that, because as I say, there's lots out there that you can use, in terms of training, but also events that are happening such as this, and our regional events. And we do a monthly e-newsletter to help remind people that the forum's there, but also give the headlines in terms of what's being discussed, and signposting people to, because we know people are busy, but if they see that email, they think, oh, that I'm interested in that, or log on and see what's happening. And as I've said already, we recently opened up the network forum to beyond the England networks, so please feel free to log on there and see what it's about. And if it's not for you, then you've not lost anything by joining up and having a look. And even if you find one thing, then it's probably been worthwhile. So as I say, we've had over 1,000 posts in terms of people sharing or helping each other. So again, that's something that I'm particularly proud of, and something that the networks is proud of. We've got a website. It's not the greatest of websites, and again, we get compared with the multi-conglomerate organisations that have got data wizards. As I say, ours is a £300 a year budget, and we've got volunteers just running it. So, but it's important to get your message out there, as I say, and we can use that, as I say, to signpost people to our meetings, and people can then, without having to contact anybody, can find out when the next meeting is. We've also tried to be doing some proactive work, because we realised that across our networks there was the importance of language, and sometimes in clinical audit we're talking about completed projects when they're not actually completed. So, because I've already said, clinical audit's a cycle, we sometimes collect the data, write an action plan, and then say that the project's completed, but actually that's not completed, that's just the start of the audits, particularly if we didn't comply with the standards. So we're now trying to do some language talk in terms of talk around completed cycles, and again, at the end of that cycle, you make an assessment about whether the actions you can take within that team are going to be able to affect the results, or whether actually you need to put it on the risk register to say we need some extra resources, or we need extra manpower, or whatever it might be. So again, we're trying and unify that across England, so that we're all talking about the same thing and the language is the same, but we're dealing with the same outcomes in the same way, because as I say, it's not always the same, and we shouldn't be giving out the message to juniors or anybody who's new to the project that it's new once the action plans have been developed. And we've also using our expertise to write guidance now as well. So HQIP wrote a guide on using stats to analyse clinical audit projects. So we've helped with the review of that this year. And again, as a result of that, we're able to influence and use our expertise to feed back to the clinical audit population, because again, that goes beyond the shores of England, and HQIP guides are now universally used. So what is it now from going forward? So we're halfway through 18-19. So again, those priorities were largely achieved. So we've now set new ones. So over the next 2 years, we'll work towards these. So I won't go into too many of those, because I've mentioned most of them already through my talk. But as I say, the importance of it is you need to know what you want to do, and then you need to plot how you're going to get there. It's all right having a scattergun approach, but as you'll find, it won't lead to much improvement, and it won't lead to successful networking. So you need to, just like an audit, you need to have a systematic approach to your networking, and have a common purpose in terms of why you're having the meetings, why are we doing this, and then people can see and get involved as they want then. So in summary, because it's time for me to hand on the mic, is a systematic approach is needed. If people talk about quality improvement and forget about clinical audit, that's wrong. That's people have just used clinical audit or misused it in the past. So it's our job to challenge that and say, let's work together. We've got skills, you've got skills. Let's see if we can work together on a project, because the best projects of any clinical audit are team approaches. No individual consultant or clinician can actually make that much difference, particularly if they're looking at a complex pathway. So along that pathway, look who's involved in that pathway, look at the patient journey, but focus on the patient outcomes. And then if you can do that, then more people will engage with what you want to do, and call it something around that. You don't need to call it a clinical audit. Just say, we're doing a project to try and improve the outcomes of this patient cohort, and this is how we're going to do it. a bit semantics really, but as I say, it's trying not to use the right language, that you don't turn anybody off in terms of trying to baffle people with science sort of thing. So, but important, you need leadership. You can't get anywhere without leadership, either through a clinical audit or a network. So I try and do my bit in terms of our leadership, but as I say, the best audits that I've seen of where you've got a passionate clinician who wants to lead that through all the way from start to finish, as I say, and no point chasing up people. If they don't want to do something, it won't get done unless they've got to do it, and then you can performance manage that. But actually, people will do things if they want to do it because they see the reason why. And we've got to understand more clearly why we're doing something, because again, sometimes we go on the autopilot and do things because we've always done it that way, and we don't really look at what value is being added through what we're doing. So don't be scared of saying, Carl Walker said we should challenge what we're accepting through here in England. This has worked for them, let's see if it works for us, because as I say, we want to make sure our projects are making a difference for our patients, and as I say, technology helps, and that's why I'm here really today. So okay, so thank you for listening, and there's our contact and blog details and forum details and website details. So okay, thank you.